First, Lisa Ramirez has a master's in art therapy from Southwestern College in Santa Fe. She's a licensed chemical dependency counselor here in Texas, and she's our Texas Opioid Response Project Director here at Health and Human Services. Also, Jessica Cance, Dr. Cance, is also the Substance Abuse Prevention Program Specialist and the Interim Prevention Lead for the Texas Targeted Opioid Response Project, and she joined HHSC in 2016 after working 6 years as an assistant professor at the University of Texas at Austin. And she has over 15 years of experience working in adolescents and young adult health promotion, including epidemiological research, program implementation, coalition building, and national evaluation projects. So without further ado, I'll let Lisa and Jessica take over from here.
All right, so Jessica is going to talk about the landscape of opioid use disorder in Texas and some of the stats, and then I'll tackle how the state is responding to that.
Hello, everybody. Can you guys hear me okay? Yes, all the way in the back? All right, so Dr. Matthews did a great job this morning talking about the national perspective in terms of what's happening with opioids, and I'm here today to talk about what's happening in Texas. So the reason we're here today is that last year, almost 3,000 Texans died due to drug overdose. And I think one of the things that's tough, I'm an epidemiology fan, so I see these numbers and they, interest me, but how do we relate this to others? So one way to think about this is that's more than the population of a Texas 6A high school. So related to, yay, Texas football, we think of our major state championship football teams, we're losing a 6A high school last year. Another way to look at it is that's more than the average population of about 60% of our cities and towns in Texas. So we think a lot about our major metros and the millions of people that live there, but when we really think about our small towns in Texas, 60% are less than the number of people who died last year due to drug overdose. And so this chart, I apologize, it's always difficult to see. See if I can do the mouse. So what we've seen is our consistent rise in natural and semi-synthetic opioids. Heroin is this sharp shooting here. And then down here is our synthetic opioids. And I start with this chart because in Texas, we have a different look than the nationwide trends. So in Texas, about 40% of our drug overdoses last year involved opioids. So in other states, that's as high as 60, 70% of the drug overdoses are due to opioids. So we like to start with this, which is to say, in Texas, it's not just opioids. And so actually, what we see is that this light blue line, now last year, the highest involved substance, and again, this is based on drug toxicology screens, was psychostimulants. So this is including methamphetamine. Next was actually cocaine. So it wasn't heroin as the primary substance, it was psychostimulants and cocaine. In addition, we have seen a dramatic rise in the number of drug overdoses involving benzodiazepines in the state of Texas. And you'll see, if you're the data person who decides to add up each one of these categories, it doesn't equal the 2,800 because we know that a lot of our drug poisonings are involving multiple substances. And last year, about 25 to 30% of our opioid-involved poisonings involved benzodiazepines. Okay, but we're here today talking about opioids. And so when we again take the bigger picture of self-reported opioid misuse, the National Survey of Drug Use and Health showed last year about 12 million people in the US aged 12 or older said that they had misused opioids at least once in the past year. And so this misuse may be, taking more than you were prescribed, taking in a way different than it was prescribed, or taking it when it wasn't prescribed to you. And so what we see is that within that data, they asked, and they just started asking a few years ago, why were you misusing? What's the primary reason for that misuse? And it varies across the ages, but overall, the primary reason for misuse was chronic pain. Among Texan students, we at HHSC have two surveys. We have the Texas School Survey, and we also have the Texas College Survey. And so our survey data showed that among students grades 7 through 12, so a little bit older than the National Survey of Drug Use and Health, about 4% said that they had misused opioids in the past year when we think about the pill forms of opioids, but 9% said that they had misused codeine cough syrup. So when we're working in the prevention side, we're trying to emphasize it's not OxyContin or hydrocodone when we're thinking about opioids for kids. It's actually codeine cough syrup. Now, when we look at our college survey, only about 4% misused opioids, and here we start to get into some of those socioeconomic factors of education and different things. So we actually see that the rates are slightly lower than you would expect. And so then when we compare our Texas data to the US data, looking at the National Survey of Drug Use and Health, the yellow bars are the US and the slightly orangey red, we'll go burnt orange, right, is Texas. And so what you see is that across the board, it's 12 to 17, for those of you that might not be able to see it, 12 to 17 is the first pair, 18 to 25, 26 or older, and the last two is the overall sample, the 12 or older. And so what we see is across each of these age groups, heroin use was more likely nationwide than it was in Texas. We had lower rates. But when you look at pain reliever misuse, all of a sudden we're on par. We actually see that our pain reliever misuse is pretty close. And actually among those 12 to 17-year-olds, we see use is a little bit higher. Again, comparing though the survey I showed you just a few minutes ago, or a few seconds ago, here we're saying it's about 4% past year misuse. Well, that matches with the school survey that showed 4% misuse of other opioids. This survey doesn't specifically ask about codeine cough syrup as a separate section. So again, thinking about youth use, we're worried that we're missing something here. So when we go back to looking at opioid-related overdose death rates, and again, on the left hand is Texas, on the right is the US, what we see is that Texas is seeing a very similar pattern in terms of the interaction between our prescription opioids and heroin, and so, but not to the same significant extent, right? So the top line is our prescription opioids, and we see that there was a rise, and then around 2007, 2008, it leveled off in terms of the primary substance that was found in the toxicology screen. And during that same time period, we see that second bar, the heroin, starts to go up. So this is what we've been hearing this morning. As we start to reduce the supply of prescription opioids, we see a replacement with heroin. Now, one thing that is hopefully a little bit obvious with the data, maybe not so obvious, is that bottom line, the synthetic opioids, this is where we start to think about things like fentanyl. And we do not see yet the same impact of fentanyl in our communities. However, we say yet because we are hearing from all of our outreach work that fentanyl is here and it is going to get worse. And so this is the opportunity for all of us to be working together because we want to keep our lines from spiking up the way that we've seen nationwide in the past 2 years. And this is really important because we can look at this data in a different way. This is just playing with it and thinking about the proportion of opioid-related deaths as they fit in with the United States. So in terms of our overall population, we are about 8% of the nation's population. And so what you can see is when you look at heroin, that top line, up until about 2011, Texas deaths were actually overly represented in the national picture. So it wasn't until the last 4 to 5 years that we actually started to see, okay, Texas doesn't have the same level of heroin-related overdose deaths compared to the nation. And then we've always seen that prescription opioids are a little bit less. But again, the synthetic opioids, up until the early 2000s, we actually had more deaths in Texas than would be expected given our population. And so the reason why I think it's really important for us to think about this is that when we think about our broader community infrastructure that might be supporting opioids and thinking about these market forces of if we have people who are seeking opioids and they aren't able to get them in a traditional setting, you know, we know that they are turning to illicit forms of opioids. Opioids, and particularly illicit opioids like heroin, have been in the state for a very long time. And so we, again, have to be thinking about this from a public health prevention perspective because heroin's here. It's always been here. One of the reasons why this has been such a big national conversation is that heroin has entered communities in the United States where it's never been before. Texas is in this very unique position where it's already here. So if we don't start acting as a community now, it will get worse. And so now I'm going to turn it over to my colleague Lisa, who's going to talk about what we are doing.
Thanks, Jessica. So in this slide, we can see our opioid treatment services locations. So in terms of funded treatment slots, here we have represented just about 16 state-funded treatment slots for the indigent. However, there are 85 licensed opioid treatment providers in the state. So in 2016, of 5,381 persons with opioid use disorder that were admitted to state-funded treatment, only 785 actually entered medication-assisted treatment, so that's about 14%. So various studies, including systematic reviews, have found that MAT can cut all-cause mortality among patients by half or more. So this slide represents the full continuum and array of services. And so I just wanted to mention here that that Texas received a grant due to the 21st Century Cures Act. And our award was based on unmet treatment need, and we received the second highest award in the state. And it's really the first time that we've received this kind of funding that really addressed the full continuum from prevention, intervention, treatment, and recovery support services. So we've really taken advantage of that and kind of broken down our silos and are really looking at integrated and collaborative care approaches. So this basically highlights the basic components of the Texas targeted opioid response, which is the outcome of the STR, state targeted response to the opioid epidemic grant. And that is $27.4 million a year that we're using to fund training, safe disposal, expanded medication-assisted treatment, recovery support services, et cetera. So in terms of prevention, we're really looking at making sure that physicians have access to appropriate prescribing guidelines. And that doesn't just mean limiting prescribing on the front end, but making sure there's appropriate tapering on the back end, as we've heard others mention. It's so appropriate to handle patients that have chronic pain appropriately. And then also it's kind of exciting to think about the fact that we could include in these guidelines aspects such as emergency department induction onto MAT, really including all those elements of the full continuum. Developing marketing campaign to increase the utilization of the prescription monitoring program. Again, looking at limits on the front end, but recognizing that we have to include interventions that address the fact that there will be increases in illicit substance use once we place limits on the front end. Really supporting safe prescription drug disposal. And I was really impressed to hear Jessica tell me that they've, through take-back events, disposed of 7,500 pounds of prescription medications, and as she says, that's about the size of a pickup truck. So it's a lot of medications that we're taking back through these safe disposal programs, but we also want to look at limitations in the availability of those prescription medications in the first place. And then expanding the universal prevention program is important as well. In terms of our training, we talked about stigma earlier, and really ensuring that our workforce is prepared to address the stigma through MAT advocacy, that we're addressing the co-occurring disorders, mental health and substance use disorders, through suicide prevention and overdose prevention together, overdose prevention training and dissemination of overdose reversal medications, and then basic information for the community about opioids and the opioid crisis. In terms of intervention and treatment, we're expanding our outreach to individuals with opioid use disorder with specialized professionals that can outreach and intervene early on, and then provide those patients with linkage to care and access to care, and overdose reversal medications and training. We're expanding medication-assisted treatment, both in terms of slots and geographic access, because as we know, this is a daily outpatient treatment for most. And then adding treatments for comorbid conditions such as hepatitis C. 68.3% of individuals entering our medication-assisted treatment sites were testing positive for HCV, and the only thing standing between them and the cure for HCV was about $800 in labs. So we wanted to make sure that we were providing reimbursement for that treatment. We've expanded the office-based opioid treatment as a new service type, and currently we've expanded to 8 LMHA, local mental health authority sites, and we've received reports that in just the first month of providing this new service, those individuals went from being unemployed to employed within just a few weeks. So we're really excited to see that these new programs are really showing some great outcomes in terms of sustainability and patient stability. In addition to all these treatment approaches, another avenue that's not listed here that I do want to mention is that we've heard a lot about value-based reimbursement and value-based reimbursement for MAT. So we've collaborated with our partners at with Medicaid to look at more of a value-based reimbursement by reimbursing their reimbursement rate for patients who are very stable receiving take-home doses, who are also receiving services that are recovery support services that are not reimbursable through Medicaid. So through this initiative, we're able to make that reimbursement complete. In terms of recovery support services, we're expanding our peer reentry programs, knowing that some of the most vulnerable individuals to overdose are those reentering from, those being released from incarceration. We're expanding our sober living support employment programs and hiring recovery coaches, hopefully with a presence in emergency departments and with linkages with emergency medical services. Part of this, a lot of the work that we're doing in Texas is not funded by the opioid STR grant and the TTOR funding. A lot of what we're doing now that this is a public health crisis is we're collaborating and aligning ourselves with the larger HHS strategy at the federal level. And so in terms of improving access to treatment and recovery, we're really boosting the support of screening, brief intervention, and referral to treatment. Because when you have physicians that are utilizing the prescription monitoring program and identifying patients, they're often left wondering what to do next. And the next progression, the next step, is utilization of screening, brief intervention, and referral to treatment. So we're really looking at supporting that initiative and keeping that in the conversation when we talk about utilization of the PMP. It's so important to complete that continuum and link folks to appropriate treatment, to the evidence-based treatment. In addition to that, I mentioned the value-based reimbursement for medication-assisted treatment, and on the services for the indigent, the medication-assisted treatment is bundled and as recommended by CMS, and we're looking at making sure that all those services are encompassed within the reimbursement rate. Data 2000 waiver trainings, we're working with the maternal child health on the maternal opioid AIM bundles, and we have a really exciting project. Dean Johnson mentioned in his presentation that there's a very obvious gap in patients who, in overdose survivors, who are in the emergency department, they're in withdrawal, they leave, and then they die of an overdose, soon after. And that's a very obvious gap that needs to be filled. Through collaborations with our EMS services, our emergency departments, and recovery support services, looking at recognized national models and combining them together, we can ensure that that gap is filled by providing same-day induction in the emergency department or at other sites, clinic sites. We can ensure that EMS are following up with these patients to ensure that the patients are safe and ensure linkage to care. And then in addition, recovery support services to support those individuals in the few days after the overdose event. So in terms of promoting the use of overdose reversing medications, we want to make sure that there's not only Medicaid reimbursement for these medications at pharmacies, but in terms of community-based organization sites, they're providing a lot of these overdose reversal medications. So some of the conversations that we've been having with our partners in Medicaid is about expanding that reimbursement at those sites. And then in addition to that, supporting the utilization of the PDMP, the first responder use of our OD mapping, so we can look at use free mapping tools to get real-time data on where these overdose reversals are occurring, and then respond appropriately using our strategies effectively in those affected communities to respond better, build up our supports in those areas that are more affected, and do that in real time. Also, creating an opioid data page, which Jessica will be working on. And then again, in terms of safe prescribing guidelines and making sure that physicians are not just considering the limitations of opioids in the first place, but also looking at responsible tapering and such. So some current barriers to our substance use disorder treatment is consistency in SUD-related policy and guidelines across all of our systems. So ensuring that, for example, American Congress of Obstetricians and Gynecologists guidelines are being adopted both in our system in terms of behavioral health, but then also in our child welfare systems and our criminal justice systems. So making sure that there's consistency in SUD-related policy. In terms of lack of geographic access to the full SUD service array, as you saw on the map earlier, when you're looking at a daily outpatient treatment, you can have areas of the state where an individual would be required to drive 2.5 hours each way just to get state-funded treatment. So we want to make sure that we're addressing those gaps by providing treatment on demand and really taking an assessment of the locations of where we need different types of treatment. Lack of engagement and retention of patients with substance use disorder. The recommendation is to improve linkage from healthcare systems to recovery support services, increasing the presence of our recovery support services in emergency departments, and that they have relationships with our EMS, which are often our front door to public health. Lack of screening and appropriate referrals to treatment in the healthcare systems. So we need to increase training and implementation of screening, brief intervention, and referral to treatment, as I mentioned earlier, and just ensuring that we know what types of treatments are available, what are evidence-based treatments for certain substance use disorders, and so forth. I think that's all we have.
We have time for a few questions. Sorry.
Yes, can you clarify what we're doing on the community level for the production or support of interdisciplinary pain centers? I know that you talked some about buprenorphine and medical assisted treatment, but what about some of the other alternative modalities?
So you're talking about modalities in terms of like
Psychotherapy,
right.
Physical therapy.
yoga, exercise.
So currently, along with the medication-assisted treatment, meaning buprenorphine or methadone or extended-release naltrexone, along with those comes with behavioral counseling and behavioral therapy. So that goes hand in hand. We don't separate that. We reimburse for that in one bundled rate. It's a given that those go together. In terms of reimbursing for yoga or other alternative acupuncture, we're not currently reimbursing for those types of services.
But that will be.
Here.
That will be part of our talk tomorrow at noon on alternative payment models. We're going to be able to talk about episodes of care, bundle payments, and et cetera, where we can start to get at these alternate modalities for therapy and hopefully find ways to reimburse for those.
Yeah, and really with these funds, it's meant to treat the opioid use disorder, not necessarily to avert the potential opioid use disorder as a result of chronic pain issues. Does that make sense? Yeah.
You mentioned recovery support services. Does that include sober coaches? I know that
Yes.
there's legislation about making that reimbursable.
Yes, and I believe, I know, Robert, you're working on, I think that's 2019. 1486. Yeah, so yes, through Medicaid, that will be reimbursable. Through the indigent care funding, right now, state funding, that is reimbursable. So we are, and it's not a fee-for-service rate structure, it's a cost reimbursement structure currently. So absolutely, yes. On the indigent care side, we are currently paying for those services. And then looking towards the future, Robert's instrumental in working on that initiative.
We have a session tomorrow on peer support and recovery services.
Yes.
Thank you for a very informative talk. I deal with the legislature a lot with reactionary actions of the legislature, and I'm really concerned about our database being so old, 2015, 2016. Tell us a little bit about what you're doing to get current data so we can work with our legislatures instead of being reactionary to really old trends.
Yes, so we've been talking a lot in the Department of State Health Services, which actually I'm moving to as of next week. So part of doing this work has made me realize we need to be doing more for real-time data. And the great thing is that there have been a lot of systems working towards that, and we are almost there. So, for example, the EMS data, they just transitioned to a new system last year. So now, starting this year, they will be able to have real-time data. So we'll be able to see where are those overdose calls going out. Were they able to use naloxone? Did it require 5, 6, 7 doses of naloxone? So then we know those might be some of our hot spots. Same thing, getting getting hospitalization data out there faster. And, you know, the difficult thing with overdose data is that it takes time to confirm the data. And so we are about a year lagged typically. And, you know, one of the things that we're working on with a couple of my colleagues, I'm like looking to see, I see Rob and Joel, they're preventive medicine physicians that are in DSHS, and we're working together to do a survey of justice of the peace to figure out barriers related to overdose death reporting, because we have 254 counties, which means we have 254 different ways of certifying and classifying a death. And so we want to find out, is it barriers in education and training? Is it barriers related to the stigma that we're talking about in general? And trying to get at some of those things so that we can have better education and training to have better data to inform our decisions. Hope that helps.
Yeah, one last question.
Oh, I just want to add to that, the high-intensity drug trafficking areas, OD mapping tool is a free tool for traditional first responders to provide real-time data on overdose reversals. And so we're initiating that with our First Responders Comprehensive Addiction and Recovery Act funding in Bexar County, and looking to expand that throughout the state as well. So that, again, will help us to better organize our strategies and approaches as we get those hotspots coming in real time.
Hi, thank you very much for sharing with us all the excitement that's going on in Kansas to address these issues. One of the big problems I'm hearing from multiple state partners is that alignment within the governmental organization. And you talk about, you know, the different agencies getting together. Have you implemented structural requirements that facilitate those kinds of relationships across state agencies? And if so, is it something at the top, you know, sort of like the governor's talking about this, or are there other ways that you're working with them?
Do you want to tackle it?
I know that in our day-to-day operations, we're having several structured meetings. For example, our public health work group meeting, and several of these initiatives, for example, the death certificate data work was an outcome. That's an example of that meeting, working with EMS. That's all an outcrop of that public health meeting. There's also meetings that we're having regarding the opioid epidemic with criminal justice and law enforcement, structured meetings with our child welfare agency, et cetera. So that hasn't been mandated. It's just been an organic outcome of the work that we felt we needed to do with this initiative. Not necessarily funded or mandated, but just part of the work we feel we need to do so that we all can understand our roles and define our roles in addressing the larger opioid epidemic.
And then one thing just to add on to that, outside of just the opioid crisis, we have our Behavioral Health Advisory Committee that is housed within HHSC, and that is a broader committee of stakeholders really looking at behavioral health from all perspectives and across the lifespan. And so one of the things that we've been able to do is bring the conversation about the opioid crisis to that committee that has already been talking for years about the behavioral health infrastructure throughout the state and collaboration. So we're making sure that we're doing it like grassroots effort, you know, us going to meetings, but then also making sure that we're tapping into some of these broader behavioral health systems that are already in place.
Great. Well, with that, we'll wrap up this presentation. I want to thank you again.
Thank you.
Just a couple of acknowledgments, and then we're going to break for half an hour before we come back for lunch. Actually, we'll come back precisely at 12:30 for lunch if we could. And during that time, we're going to have a much deeper introduction to Project ECHO and the role that it plays. And really this afternoon, there's going to be two themes that I think we'll be tackling. One is, again, ECHO, and I think how fundamentally it'll help us to transform the healthcare system here in Texas. And secondly, the role of functional improvement in helping people that have chronic pain deal with these issues and gain back the skills and resources that they need to get back with life. I did not mention the incredible teamwork that it took to make this all come together, and I want to acknowledge the folks at Superior that really made this happen, and including Stacy and Katie and Brittany and Arisa and Adele and Michael and all of the folks that have really helped so much to bring this all together. I couldn't have done this without them. I also want to acknowledge somebody that's in the room here that's been really helpful with a lot of the work that we're doing and with the state agency, and that's Sherry Neese Todd with Rutgers. Sherry, could you raise your hand? She helps to run an organization that is this collaborative approach between state Medicaid agencies across the country, managed care organizations called SMINET, Serious Mental Illness Network. And we have learned so much from participation with SMINET over the years. Really these great conference calls where we can hear what other states are doing around these issues. So it's been a great thing to be participating with, and I want to thank Sherry and the work that Rutgers has been doing for that. So thank you.